Welcome, everyone. I know you've been patiently waiting in our waiting room, and many of you are already on with us. Thanks so much for joining us for this virtual UMiami Health Talk, a highly popular one, diabetes management, GLP-1s, and healthy eating. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Comprehensive Diabetes Center. UHealth's Comprehensive Diabetes Center offers expertise from a multidisciplinary team. We treat patients who have type 1 and type 2 diabetes, secondary and genetic forms of diabetes, highly complicated diabetes, and diabetes during pregnancy. Customized treatment plans that fit into your lifestyle using the latest advances in diabetes treatment, including promising new treatments through clinical trials. Expert care and a full range of resources to make living with diabetes just a little easier. We invite you to learn more about UHealth's Comprehensive Diabetes Center by visiting umiamihealth.org/diabetes and call 305-243-3636 to schedule a consultation and screening. No worries, it's early on. You're going to get that number and that website again afterwards. So we will remind you. Plus, this webinar is going to be recorded. So all of you registrants who are on with us tonight will receive this recording about a week after we're done. But tonight, our experts are going to discuss the latest breakthroughs in treatments and interventions. At the end of the presentation, there's going to be a Q&A session. That's a unique opportunity for you to ask direct questions of our experts. Take advantage. Use the Q&A feature at the bottom of your Zoom screen. Take a look at your computer and see where it is. And that's where you're going to enter the questions, and we're going to prep them for our panel. So let's begin with our first speaker, and that is Dr. Gianluca Iacobellis, a professor of clinical medicine and director of the UHealth Diabetes Service at the University of Miami. He's a leading authority on epicardial fat and pioneered the echocardiographic method used to measure it. Dr. Iacobellis has published extensively in top journals, and his work has reshaped our understanding of the heart-adipose connection. Right now, he is currently leading multiple investigator-initiated studies and NIH-funded trials on EAT and cardiovascular disease. Dr. Iacobellis, let's begin with you, and let's see your presentation. And unmute yourself. There you are. You can begin sharing. Excellent.
Thank you, Ileana, and good evening, everyone. So thanks for joining this webinar. So you're very welcome. And so I'm going to tour you through a very interesting journey. And so I want to start with this slide showing the strong interconnection and relation between diabetes and obesity. So these two conditions are really very connected, and targeting one will benefit the other one. Particularly, targeting obesity could lead potentially to, I would like to be very provocative tonight, to potentially resolve type 2 diabetes, or at least reduce all the important cardiometabolic complications associated with diabetes that affecting your lungs, your heart, your brain, your eyes, your joints, or your kidneys. All of these may be improved, potentially resolved if we reduce the excessive, unhealthy adiposity, not necessarily just obesity. So we have now tools to target and to address these cluster of condition, so diabetes and obesity, and with well-known weight loss medications or diabetes medication. So I'm going through these many options we have, because there is many non-scientific information that I like to give you a very fair and accurate information about these medications. So there are several options. The two most commonly used are the semaglutide, that is under the commercial name of either Ozempic, indicated for diabetes, and or Wegovy, indicated for weight loss and cardiovascular protection. And to give you the sense, this is a weekly pen. So you receive a pre-filled pen with a medication with different doses, and you inject in your subcutaneous area only once a week. It will take 10 seconds. It's very simple, really painless. And with this medication, studies are clearly show, you can see the slope, that you could lose up to 20% of your initial weight, which is amazing. We were achieving these results with surgery until a few years ago with brain surgery. Now you can achieve these results with the weekly injectable medication. There is another molecule called tirzepatide, which is under the commercial name of Mounjaro, indicated for type 2 diabetes, and Zepbound, indicated for weight loss and obstructive sleep apnea, which is similar, is another pre-filled pens that you inject weekly in your abdomen subcutaneously. They're disposable pen, a very easy, very friendly device. And with this medication, you see, compared to this is a placebo, means a pen that looks like the medication, but it's not medication. Compared to the real medication, you see big difference. And people in many of these studies were able to lose about 25% of their initial weight loss. These are real numbers. So these are numbers that we see in the clinical practice, not just in the clinical trials. How do they work? So they have multiple effects. So one of the most known effects is actually one of the less important effects. So they increase satiety, they reduce appetite, they delay the gastric emptying. So they make your digestion a little bit slower. They modulate the receptors we have in our brain, and they will make you feeling fuller after eating a smaller portion. But this is, again, it's just a portion of the effect that they do, because they also stimulate insulin secretion. And we'll see that we may also see some beneficial effect in people with type 1 diabetes. And they mainly, of course, improve the glucose control, which is actually one of the earlier effects of this medication. So you may have a better diabetes control, and your A1C can drop earlier and faster than your weight loss. This is a common experience. But they have more profound changes within the adipose tissue metabolism. We were the first one to show that actually there is a direct effect on the adipose tissue of the heart, adipose tissue of the liver. So this is a very peculiar and interesting mechanism. So as you can see, they basically target all our organs, or most of our organs. So they're really pleiotropic. We define that. What that means. That means that they target the skeletal muscle, the adipose tissue, the pancreas, the kidney, the circulation, the heart, the liver, and also the brain. So you have a medication in one shot, literally, you can target and improve most of our organ functions and morphology. So, as I mentioned, we were the first one in the world to show that the adipose tissue, so the fat that is infiltrating your heart here, you can see this is your heart, this is the fat of the heart, the epicardial fat, responds and decrease to these medication, either the semaglutide or the tirzepatide. And when you do that, people are no longer dying because diabetes, because obesity. So these medications are able to reduce the risk of dying or having heart attack, stroke, because of diabetes. And one of the mechanisms seems to be mediated by the effect of this medication on the adipose tissue of the heart. So, but more recently, these medications, so the semaglutide particularly, are shown to be extremely beneficial for your kidneys. So if you have a chronic kidney condition, or you have an early kidney condition like just positive macroalbuminuria, you are diabetic, but your creatinine is normal, but you are in an early stage, you are potential risk of having kidney problems. If you take the GLP-1 agonists, particularly the semaglutide, your risk of having your kidney condition progressing or worsening is reduced by using the semaglutide. So the current indications, I want just to clarify that because this is a common question, a common problem in clinics about insurance coverage and indications. So there are medications that are officially, formally indicated to treat type 2 diabetes. So there are Ozempic, Mounjaro, Trulicity, which are the weekly injectables. So Trulicity is the second generation. Ozempic and Mounjaro are the third generation, the newer generation. But there is also daily injectable Victoza, Byetta, and there is also an oral version of the semaglutide called Rybelsus. So these are all indicated for type 2 diabetes. If you don't have type 2 diabetes, but you're overweight with some condition related to your overweight, or you are considered obese according to the BMI, you are eligible to use Wegovy, Zepbound, also the Saxenda, which is the daily GLP-1, the second generation. But if you're not obese, if you're not diabetic, but you have a history or higher risk to have high cardiovascular events, you may qualify for Wegovy alone, even if you are not obese or if you are minimally diabetic. Again, if you have a risk of kidney disease because of the diabetes, you are eligible for Ozempic. And lately, this is very interesting, if you have sleep apnea, which is common condition, often underdiagnosed, which increase your risk of heart problems and diabetes, you are eligible to use Zepbound. So another common topic is contraindications. So doctor, can I use a GLP-1? Can I use Zepbound, Wegovy, or Mounjaro, or Ozempic? So there are few actually contraindications. So one is if you have a history, you personally had a history of acute pancreatitis or pancreatic cancer. I have to say that this is the original warning box. However, there are many studies that they are now showing that the risk of developing a pancreatitis or pancreatic cancer while using this medication is not superior to any other medication. So that means that the risk of having a pancreatitis is the same that if you use another medication. So, however, is still a contraindication. So another big contraindication, but it's a very rare condition, very extremely rare. If you have a history of this condition called multiple endocrine neoplasia, where you have a family history, your personal history, multiple tumors, particularly one called medullary thyroid cancer, very rare. So if you have a thyroid nodule, which is benign, the biopsy has shown that it's benign, you have no problem using this medication. And of course, as now, they are contraindicated if you are pregnant. So what are the most common side effects? Mostly are gastrointestinal. So most of the side effects are mild, are very well tolerated. Of course, the gastrointestinal side effects are subjective. People that tolerate better, people tolerate not as good, but the nausea at the beginning, but it's not a nausea that brings you to vomit. So you may feel some heaviness on your upper chest. You don't want to finish the full meal. That's the type of nausea you may have. Diarrhea is not that common. Abdominal pain is mostly some bloating, but it's very mild and tends to dissipate with time. And remember, medication half-life, that means how long a medication works is actually about 3-4 days. So you may see the best effect on the appetite at the beginning and also some mild gastrointestinal problems at the beginning as well. Constipation is a common problem, but in the long term with the high dose of the medication. So another topic of interest There are many non-scientific press bring it up. Okay, I'm Ozempic. I'm going to lose muscle. I'm going to lose a lean mass. So it's not a good medication for me. So, however, there are many studies showing actually the opposite. And I want to clarify that if you're with diabetes or with obesity or with both, you likely are carry on excessive and unnecessary lean mass. So you have excessive fat mass, but also you have excessive lean mass that you don't need. And that excessive lean mass is not giving you any muscle strength. When you lose weight on this medication, you actually have a proportion reduction of fat mass, which is superior, and a proportional reduction in the lean mass, but your muscle gets stronger, so you have more energy. So this is it's a concept that needs to be definitely reconsidered. So should you be concerned about psychological side effects? So, at the very beginning, there were some concern about people having bad thoughts, suicidal thoughts, or changes in their behavior. So there were two big studies, one conducted in the United States, one in Europe, and both ruled out any correlation between the use of these medications, any mood changes or other more serious consequences. So this is more recent. The doctor, I'm going to do a procedure. I'm going to do a procedure that requires a general anesthesia. So is it safe for me to use the GLP-1? It is safe, but the current guidelines are recommending that you pause using the injectables at least a week prior to do the general anesthesia to avoid any risk of problem during the anesthesia. It's not a problem. Why? Because this medication the beneficial effect will stay in your body, in your system, even you pause for a week. So, big question, what happens if I stop it? So that's a $1 million question. We have some answer. So if you stop, you are likely to regain the weight, but there are some, you can see that the slope is going down, 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 and then you stop here and you regain, but you don't regain back to the baseline. You regain some weight, but there are some very recent study, showing that actually people, particularly on the tirzepatide, Mounjaro, Zepbound, when they are completely off of the medication, they are able to keep at least 30-40% of the weight they have lost. Why? Because the metabolic and changes of this medication they last longer than we think. So this is my last slide about it's more a warning. So these medications are costly. Some of the insurance are not covering. So people may I don't want to say they are looking for alternatives, for some options. So there was in the recent past, or currently there is still use of this compounded. So I would highly discourage you to use compounded for three reasons actually. First of all, they are illegal. So then they are again illegal. They are not FDA tested. And they are not the same compound, the same molecule, actually. So these compound, they are salty medication. They have a different DNA, and so definitely, so don't use any compounded medications. I finish here my presentation.
Thank you, Dr. Iacobellis. Very, very specific, and that's good because I'm seeing a lot of the questions coming over, and people are asking these very things. So you're getting right to the heart of the matter. So let's tee it up now for our next speaker, Elizabeth Ferrer, a registered dietitian and certified diabetes care and education specialist at the University of Miami Comprehensive Diabetes Center. She specializes in diabetes management and technology, helping patients improve their quality of life through personalized nutrition and wellness. Let's welcome Elizabeth. It's all
Thank you
yours.
so much, Ileana. Let me go ahead and share my slides. All right. Can you see my slides all right?
Yes, I think you need to put it in the presenter mode.
Perfect.
There you go. Got it.
Awesome. So I'll be talking about diabetes treatment in the era of GLP-1 medications. A lot of what Dr. Iacobellis had mentioned with things like approaching the side effects is going to be very important. And that's what we'll go through today on the nutrition strategies. And then also the role of healthy eating and balanced diet as well to enhance your metabolic health and optimizing your treatment outcomes while you're on a GLP-1 medication. I personally think all patients that are prescribed the GLP-1 medication should be seen by a registered dietitian, just because it's going to be really helpful for managing the side effects, unfortunately, that some patients may experience, and then also any type of weight loss or managing diabetes and blood sugar goals that that patient may have very individual approach. So right here, we're going to focus more on side effects and nutrition tips. So if you are someone that is on a GLP-1 medication and affected by nausea or vomiting, some nutrition tips that we can do are trying to eat smaller, more frequent meals. If we go very long periods of time without eating, as Dr. Iacobellis mentioned, these medications do decrease your appetite. So you don't eat probably irregularly scheduled meals. This itself, going long periods of time without eating, can also result in some forms of nausea as well. So we do want to make sure that we're not going, I would say, 4-6 hours maximum without eating, especially if you're active throughout the day. This will also help digestion, and we'll talk about that in a bit. Following a low-fat diet. So fat is one of the macronutrients that delays gastric emptying. And like Dr. Iacobellis mentioned, these medications, one of the ways that they work is by delaying gastric emptying. So we don't want to also delay gastric emptying even more by having high-fat meals. So for example, staying away from most fried foods, fast foods, and greasy foods are going to be foods that are going to be very high in fat and could delay gastric emptying. Eating a little bit slowly always helps with nausea. Stopping eating when you're full. So some people are a part of the Finish Your Plate Club. And with these medications, we really have to listen to your body because you are going to feel fuller sooner. So listening to that kind of brain sensation that you're getting of feeling full. And it may come a lot quicker when you are on a GLP-1 medication. So trying not to eat past that. Avoiding strong smells, drinking ginger teas. If you are having a lot of nausea and vomiting, you do want to stay away from caffeine. And then keeping a food diary always helps to make any connections if you continue to feel this way. Then with constipation, this also results from the delayed gastric emptying. So things are moving through the digestive tract a lot slower. So we do want to mitigate this by trying to do our part of increasing your fiber intake and also making sure you're drinking enough water. So we want to combine having enough fiber from foods like fruits, vegetables, whole grains, even nuts and seeds. And if you're doing a great job with eating a lot of fiber, we want to match that with drinking enough water so everything moves through your intestines smoothly. That's about 64 fluid ounces. This is a very general recommendation. It depends on the person, your activity level. If you're outdoors, you may be sweating more. So this is a good minimum to make sure that you're hitting, which is 8 glasses of 8 fluid ounces a day. Increasing your physical activity. So with movement also comes movement if you're feeling some constipation. And this could be for if you're on the GLP-1 medication or not. And then seeing if your physician or dietitian recommends any type of fiber supplement or stool softener as needed. And then diarrhea, which Dr. Iacobellis mentioned, is not as common with these medications, but there may be some patients that feel that they have some diarrhea. You will be a little bit more dehydrated, so staying hydrated will be important. Sometimes it's not just water. We want to make sure you're getting the electrolytes as well. Limiting dairy products, alcohol, soda, coffee, and caffeine, and then avoiding sugar alcohols. Sugar alcohols don't get digested and absorbed the same way as regular sugars do, so they can actually cause more of diarrhea or dumping syndrome. So those are those sugar-free products that may end in ITOL, like sorbitol, xylitol. Those are ingredients you can look for to avoid. So meal planning tips. The key here is to choose variety of nutrient-dense foods, including fruits, vegetables, whole grains, lean sources of proteins, low-fat dairy products or dairy alternatives, and healthy fats. And how we can do that, we'll see in a little bit more visuals, so you can start getting some ideas. From what we were talking about before, the small frequent meals is important, especially since you may not be feeling much hunger. A lot of being on this medication and doing the right thing when it comes to nutrition is not so much that you're going to eat less on these medications, because your food intake is going to come down and your appetite's going to be suppressed. But what are we eating less of, and what are we eating from the smaller portions is going to be the most important. So we want to think quality and also quantity at the same time. So setting scheduled times to eat will be helpful to avoid that nausea sensation. So those smaller, more frequent meals, that doesn't mean you have to eat 6 times a day. Maybe that looks like 4 small meals or even snacks. Basically, instead of having 2 large meals per day, this may help your digestion quite a bit. Then we have increasing your fiber intake. So to give you more numbers as to what a high fiber diet looks like, anywhere from 25 to 35 grams of dietary fiber. Most people skip over dietary fiber when you're looking at a nutrition facts label. They'll go directly to protein or sugar or fats or calories. But dietary fiber plays a huge role to help with your cholesterol levels, improving your glucose absorption as well, and helping your gut microflora. So 25 to 35 grams of dietary fiber, or if you are following a lower calorie diet, maybe with the weight loss and being on a GLP-1 medications, it can be the recommendation about 14 grams of dietary fiber per 1,000 calories. We have 2 different types of fiber. There's insoluble and soluble fibers. Insoluble fibers are the ones that help more as a laxative approach. So if you are feeling more constipated, we want more insoluble fibers. And soluble fiber helps to kind of harden up the stool, let's say, and it lowers your cholesterol levels and improves glucose absorption. The easiest way I have to visualize this is thinking of an apple. So the outside of an apple, or the cáscara of the apple, is going to be the insoluble fiber. So we do actually want to eat that if you want to have more of that laxative effect. And then the inside, or applesauce part of the apple, will be the soluble fiber part. And then using gentle cooking methods will also be very helpful, and avoiding fried foods. So steaming, baking will be much better than having any fried foods, because of the extra oils and fats that they'll have. So smart swaps, this is a nice visual tool to remember. So if you want to take a screenshot, you can always remember this for snacks and meals. So kind of smart swap. So if you want something that's convenient, like a pizza or a hot dog, we really do want to move to more of a balanced meal with protein, vegetables, carbs. So your protein in that example could be ground turkey, your vegetables, and then you have the potato as your carb, for example. So no, the potato is not going to be considered the vegetable. It's more of a carb or starch. From having French fries or bacon, which these are very high fat foods that have a lot of poly and mono unsaturated fatty acids, would be much better than the saturated fats. So those healthier fats are things like avocados, nuts, and seeds. Instead of a cheeseburger, we can get like a salad with chicken, for example. Instead of pretzels or chips for snacks, we can opt for something a little bit higher in fiber, like hummus and carrots. And then instead of refined carbohydrates like rice, French breads, croissants, Cuban bread, choosing whole grains, quinoa, potatoes, or beans as your form of carbohydrate. Now, alluding to what Dr. Iacobellis was mentioning, a lot of people worry about muscle mass loss and are so into getting enough protein. And we also have to remember when we're trying to lose weight, we do want to be at a calorie deficit. And protein is one of your 3 macronutrients. So we have carbohydrates, protein, and fats that all provide calories. So we want to eat enough protein. Yes, it's very important to help maintain your muscle mass. We also want to do your exercise. So even if you're eating a whole lot of protein throughout the day without doing any exercise, it's really not going to do much for your muscle mass at the end of the day. So you need to use your muscles or you lose them. So that's where the activity and exercise piece of things is very important. And then matching that with enough protein. So on the right-hand side, there are protein recommendations. This can be very individual. So it is quite a big range depending on what your goal weight is. For example, for weight loss, you'll use that number in kilograms, which you divide the pounds by 2.2. And then you can get an idea of where you should be at. You could also calculate this with a registered dietitian. What are some foods that have protein in them? We always think like meat, chicken, eggs. Yes, you have plant-based also and animal-based sources of protein. So things like eggs. 1 large egg has 7 grams of protein. About 4 ounces of meat, pork, ham, chicken, and turkey have around 28 grams of protein. You also have protein in your fish and healthy fats as well. The dairy products like cow's milk, Greek yogurts, kefir, cottage cheese, and cheeses will have protein. Nut milks, I always like to mention this, like almond milk, oat milk. We can drink these, it's no problem, but don't drink them thinking you're getting protein. Comparable to cow's milk, the only non-dairy sources of milk that are going to give you as many grams of protein are going to be pea and soy milk, if you wanted to do a non-dairy source. And then the nuts and seeds are going to be more plant-based sources of protein. And then beans, couscous, quinoa, brown rice, and oats are also more of a carbohydrate-based food that also benefits from giving you a few grams of protein if that's what you're looking for. Protein is also notable for helping with satiation, and keeping you feeling satisfied. So along with protein, fiber is also key to make sure you're feeling satisfied from your meal. So we always want to make sure that you have some sort of protein with your meal or snack. It can also help to prevent any glucose spikes. So I always like to give the example before we get there with like snacks is always coupling your fruit, for example, with a little bit of protein, which could be like having it with nuts, can help the blood sugar response not be as aggressive. What we're seeing here is going to be more for your meals. These are the ADA plate methods, and it's more of a plate formula. So within this plate formula, what you're going to see is we're going to draw a line down the middle. 50% of the plate will be comprised of the non-starchy vegetables. And that could be on the left-hand side, you see a mix of cooked vegetables. On the right-hand side, you see the salad greens. So you can kind of choose your own type of non-starchy vegetable. Then at the top right, you're going to see we have the quarter of your carb or starch. So like we mentioned earlier, the potato is not going to be considered the vegetable. We're going to consider it your carb or starch. So here the carb representative is the potato, and this side it's a little bit of the rice and beans. So we can still eat these foods that we love, but we do want to manage the portions of them. And then this is also going to help your glucose response. The last quarter of the plate will be your protein, which can be chicken, fish. It could even be tofu as well if you wanted to have more of a plant-based option. Then here, this is the same plate, but more of like a key that you can use to make it your own, which is really nice. And again, this is the plate formula that you can take with you mentally, visually. I've had patients actually have a plate that looks like this and is divided. So it's really easy and nice. So you can remember how to create balanced meals. My key takeaways so far from what we've talked about is the GLP-1 medications are to improve glycemic control and will help promote weight loss in patients with diabetes. The role of nutrition is based off of managing your symptoms for sure, and then also balancing your diet with fiber, lean protein, whole grains, and enhancing the medication side effects. We do want to reduce the side effects of, like we mentioned, if you're having a little bit more constipation, try drinking a little bit more water, more fiber, being intentional behind what we're eating less of. And then professional guidance is also important. So working with a dietitian, seeing how these recommendations can work for you in your day-to-day. It's going to always look a little different for people. But thank you so much.
Thank you so much, Elizabeth. And now we're ready for the question and answer session. And people have been very active. And Dr. Iacobellis, thank you for jumping in there and answering a lot of them directly. Since we're on diet and nutrition, let's go right to this question for Elizabeth. Please discuss the large availability of online content relating to diabetes, diet, sugar control. I mean, all these online trends from intermittent fasting to keto to paleo. What do you say to any of this?
So I think it's good that there is online presence of people trying to make change. They're trying to find what diet, what works for them to lose weight or get healthy and kind of make sure that they're doing their part. So I think it is great that there is a lot of online presence. Now, what works for someone may not work for everyone. So we have to be very careful as to how we take people who may not be professionals, who may not have the data to back up whatever they're saying. And we have to be very careful. If it worked for them, it may not work for you. We also have to be careful with if they're trying to sell something, if there's like a supplement involved. So this is where we have to be cautious. At the end of the day, there is no one diet that's the best diet. It's always going to be more of an eating pattern, I like to say, or a lifestyle change or dietary change that's going to work for you, because no one person has the same medical history, the same medical conditions, the same laboratory values that are elevated, for example. So the type of diet is a difficult question to answer. Which one is the best? When we're thinking of a GLP-1 medication and weight loss, it is going to be more important about your overall calorie intake and also the quality of where those calories are coming from, so you can feel good while losing weight.
Okay, Dr. Iacobellis, let's talk about the GLP-1s. Ozempic, I guess, and Mounjaro are the ones most talked about. What normally happens, this question, when you stop taking it? Does the patient start gaining the weight back? And is there a process of, is it months? Is it years? Where are we with the long-term studies?
Yeah, no, this is an excellent question, and is still partially unknown. So I can answer the question in two ways, with research experience and clinical experience. So clinically, if a person has to stop for a variety of reasons, one of these medications, but is able to keep the profound lifestyle changes, including exercise, diet, as Elizabeth pointed out perfectly, the regain is not fast, and it is definitely not back to the initial weight. The research experience is showing that, particularly with tirzepatide, with the Mounjaro, because the profound metabolic changes at the level of fat tissue, at the heart, the kidneys, so some of the beneficial effects, including some effect on the fat cells, so on the adipose tissue, they last much longer, and so you may prevent a significant regain also for months or even almost a year, or at least you're able to maintain a 30-50% of the weight that you lost, even without the medication.
And does the efficiency of these drugs sort of decrease over time? In other words, how long can the patient take this medicine? Is it
so the short-term effect of this medication is about 3-4 days. So that's why many people are asking me, okay, is it okay if I use the injection every other week, for example, or no? So the straight answer is no, because the short effect of medication is 3-4 days. In a long term, so because, again, the profound changes, beneficial changes that we are seeing, we have studies, longitudinal studies, so studies monitoring and following up with the patients up to 4 years, showing that these medications are effective and safe in the long term. So the approach, the philosophy that we're using, these are going to be long-term medications, chronic medication as we use for cholesterol, for diabetes, and for blood pressure. And because of all the beneficial effects that I show you, so they may actually replace or some of the other medications. So I see that they may become the monotherapy or few therapy in a long term. Yes.
Yeah. So we're almost on the frontier of all these changes, and I know that you also, Dr. Iacobellis, said to somebody who asked the question whether we're going to get to the point where insurance is going to cover for most people, and you're saying we're close.
Yes, so and there are some recent news showing that some of the cost of this medication may drop or may change. So some of this medication may become more available. I know by experience that if you're diabetic, you definitely have a good chance to have a Mounjaro and Ozempic covered by your insurance. We're having a little bit more some difficulties with some insurance plans covering medication there for people who are not diabetic. However, for example, University of Miami now has a new system where concurrently when I send the prescription electronically to the pharmacy, we are able to select the exact diagnosis that is associated with the indication. So we are gaining time, and we are skipping multiple steps, and because we are also submitting the prescription along with the prior authorization. So the doctor, so what I do daily is to prescribe medication, select, request the prior authorization, and select the proper diagnosis. And this system seems to be effective and improve the coverage by the insurance.
That's breaking news. Thank you for sharing that. And before we get on to you, Elizabeth, because I know there's so many tips that you could give people to stick to a diet plan and an eating plan, and not this yo-yo dieting that we all seem to fall prey to. Let me ask Dr. Iacobellis this question that came, was one of the first ones. What are your thoughts about non-overweight, non-obese, non-diabetic patients using these GLP-1 receptor agonists for weight loss? I mean, essentially, they're using it like a diet drug.
Yes, I may say something that not everyone agrees with, but I'm actually in favor because, first of all, because the current classification of obesity and overweight has been highly criticized, because it's based on the body mass index. And the BMI is actually a very poor indicator of the body fat distribution. So you may have a very high body mass index, so you are considered severely obese, but actually your cardiometabolic risk, having diabetes, high blood pressure, and all the other comorbidities is maybe actually lower if you have a normal BMI, but if your adipose tissue is more close to your heart, your liver, and is not detected by the BMI. So that's why I think that using this medication, even in people who are not officially classified as overweight or obese, or may actually should be encouraged, because the BMI is not the right marker, because you may have a beneficial effects just by shrinking the adipose tissue in your liver, in your heart, and that will give you beneficial effects, even if you're not diabetic, if you're not obese.
But I'm assuming that you want people to have lab work done and other workups before.
Yeah, no, that's of course, it's for sure. I'm not advising to go online and to buy GLP-1 just for going to a wedding and losing 5 pounds. I mean, I understand that could be a good reason, but it's not what we usually do.
Elizabeth, and let's talk about, I love the illustrations with the plate and the breakdown of the food. If only we were always so good all the time. And I know we all do our best, but This person asks that they watch sugar and carbs, but are fatty foods of greater concern? In other words, which is worse in the long run?
Great question. And as I was mentioning during the presentation, when we're looking at nutrition facts tables, people look straight at sugar, like that question's mentioning, or maybe they're looking at total calories. So when we're looking at the label, it gives us a lot of information, and we also can see the total amount of fats. So when our goal is weight loss, the fats out of the three macronutrients that we discussed, which were carbohydrates, fats, and protein. Fats are the most calorically dense. So each gram of fat provides 9 calories, where on the contrary, the carbohydrates and protein only provide 4 calories per gram. So I say this because, for example, even if we're eating healthy fatty foods, like for example, avocados, nuts, and seeds, people can eat them and think, oh, I'm doing a great job. This is a healthy fat. But if your goal is weight loss, they're very calorically dense. So we just have to be careful and cautious still of the portions of the fats. And then also, as to the questions mentioning, the type of fat. So not all fats are bad. We have healthy fats, which are called poly and mono unsaturated fatty acids, nuts, seeds, olive oil, avocados, fish. And then the saturated and trans fats are the ones we want to try to limit and avoid. Saturated fat actually contributes a lot to the cholesterol being elevated, especially LDL cholesterol and cardiovascular risk.
Okay, let's talk about then the artificial sweeteners. So someone's asking about organic stevia versus Splenda. Obviously, try and avoid white sugar, I suppose. What do you say?
So when we're working with someone who has diabetes, we do want to try to limit refined sugars because this is going to spike their blood sugar. So if you're using anything like stevia, for example, monk fruit, I always mention to my patients, try using small quantities as needed because they are usually 2 to 3 times sweeter than regular sugar. So we just want to be really careful on how much we're using of the artificial sweeteners or any type of sweetener for that matter.
Because it actually spikes your insulin release. Is that what you say?
No. Regular sugar will. You shouldn't have any spikes with, for example, stevia or like monk fruit.
Okay. All right. Doctor, we were looking at some of the other questions coming over here that you wanted to answer live. And here's a perfect one. So is the plan likely that this becomes a lifetime medicine for many patients? And I know you're talking about the long-term effects and the science. We're still getting there. We're still learning. But what do you say to someone who says, look, I started with Ozempic as a type 2 and haven't been exercising, haven't done anything. I see the value through 3 months, and my A1C has dropped, but what is my long-term lifestyle looking like?
Yeah, this is a common experience. So first of all, the improvement in A1C are faster and earlier than the weight loss. So it's definitely a common experience because, again, these are mainly medications to improve diabetes. And the weight loss and the changes in the overall cardiometabolic risk, they require a longer treatment. 3 months is probably insufficient, but also may depend on the dose of the medication. So some of the beneficial effects are definitely dose dependent. So you may have an improvement in A1C with the low dose of the medication, which again is very fast, but you may not achieve other important goals such as weight loss and other cardiometabolic improvement. They may require higher dosage and the long term. For long term, one of the biggest question is what dose should we use, and what I'm doing is to use the best tolerated dose for maintenance. So let's say that the patients have been on one of these medications for 6 months, 1 year, 2 years, and achieve the A1C goal, achieve the desired weight loss goal, achieve other important cardiometabolic goals, but we don't want to stop it. So we could downsize the dose if the patient is on the max dose or intermediate dose, and we use the best tolerated dose as a maintenance. Can be a low dose, can be high dose, and that doesn't change because the activation of the receptors we have in our body is for maintenance. It seems to be more important than the dose that we use at the beginning to induce weight loss.
Yeah. And even more important, to your point, that people be monitored medically, because how do any of us know what dosage is correct? You know, what you start off at the beginning and then what you taper off. So that's why you need a medical professional in the picture.
Definitely, yes, I agree.
Here's a question. Since the GLP-1 stays in your body for more than one day, is it okay to take, for instance, Rybelsus every other day?
No, because the particular Rybelsus has a half-life is very, very short. So that means that is going to be metabolized by our stomach very rapidly. So if you take every other day, you're going to lose efficacy. It's not harmful, so it's not going to give you side effects, but you lose efficacy.
Okay. Elizabeth, talk to us about some tips that people can use, the daily tips, even on the snacks. We all have always tried to do the small meals. Some say 5 to 6 meals, small and the proper choices. But for instance, snacking on popcorn, everybody likes to throw popcorn in. That's high salt and a lot of other things. To give us some tips that might be helpful.
So with the small frequent meals, the 5 or 6 could be an overkill, especially if you want to lose weight, just because of the amount of calories that those 5 to 6 meals may have, right? Even if it's a small meal, it could be calorically dense. So we also have to keep the calories in mind when we're thinking of weight loss. So even if a small frequent meals looks like breaking up, like having 2 meals and 2 snacks for some people that really don't have that big of an appetite, for the snack portion of things, those can be something simple as like the little yogurt cups that are pre-portioned. A lot of the issue that I see with snacking is that it goes from being 150, 200 calorie snack to a 500, 600 calorie snack in seconds. So we don't even realize it till it's done and we're looking at the label and the serving size. So that's where, for example, pre-portioned things I think are really helpful, like the little snack packs. There's really nice ones that have like dried fruit, cheese, and nuts. I think that one's really great, especially if you need something on the go that you won't prepare. The little 100 calorie packs of nuts. You could also do the fruit. I always mention when you have yogurts, you have to be careful with the added sugars, because if it has a flavor of strawberry, that flavor of strawberry might be adding like 20 to 25 grams of added sugar, where you could have just gotten a plain one and put real strawberries in it, which is a much healthier snack, and you get more fiber from it and you don't get any added sugar. So a lot of things that are still a little processed will get you a long way, especially to help manage your calories and your portion sizes when we're thinking of snacking, because nuts is an easy one, from a quarter cup, which is unforgiving serving size, to a whole cup, which easily we can do. That's 140 calories all the way to almost 500 calories in one sitting, which again can go in seconds. So we just have to really be careful.
Yeah. And Dr. Iacobellis, here's a kidney transplant patient who says he or she has gained weight since the transplant, and would you recommend GLP-1 for this patient? I know you have.
I do. I have, yes, I have several patients, and also my clinical experience is supported by some interesting studies showing that the GLP-1 receptor analogs are effective and safe in the post-transplant for multiple reasons. One is very technical. I hope I am able to explain in a few words. So basically, some of the medications that these patients need to use to avoid rejection, they affect the ability of the pancreas to produce insulin. And this effect is counterbalanced by the GLP-1 receptor analogs. And this is one good reason. Other reason that we know that these patients may gain weight because of the steroids, because other medications, and there is no risk, unless, of course, there are the known contraindications that we discussed, but actually we see beneficial effects.
Mm. And Elizabeth, here's someone says, I've been off eating fatty foods and fried foods for a long time. And then if I wish to eat it every once in a while, is that going to have a long-term effect on my body with abdominal pain and bloating and things like that? I guess this person is probably on the GLP.
Yeah, I was about to say if they're on the GLP-1, they have to be pretty careful because the medication will almost tell you what you will tolerate and what you won't tolerate. So I have a lot of my patients mention to me when they go too far. So let's say they have 3 pieces of fried chicken versus just having one, then they'll feel very sick. So if you do want to indulge that day, I always like to say that like 90% of the time we're on the diet or we're doing these lifestyle changes, but we have to be realistic. No one's perfect, and food is very cultural, social part of life. So that 10% of the time, it's not a moderation. We have to be careful. So I like to give a number like 10% of the time, enjoying foods, but within small portions, just to make sure you don't have any digestive issues from, let's say, like a piece of fried chicken, for example. If you go a little too much on portion, then you might feel it a little bit more.
And Dr. Iacobellis, we're wrapping up soon, and it's incredible because it's gone fast. But you had mentioned that there is more research on possibly these GLP-1 drugs helping with diabetes 1 patients. Where are we with that?
Yeah, this is a very developing and interesting area. Of course, the GLP-1 remains non-indicated for type 1 diabetes, but we are using off-label GLP-1 in people with type 1 diabetes and obesity. Why? Because we are facing a sort of new phenotype. Type 1 diabetes has been historically considered very lean, very slim people, which is still true in most of the cases. But we are now facing many type 1 diabetic who are obese. Some of them are actually severely obese or with overweight, and particularly, again, with more visceral fat, more abdominal, more liver fat, more heart fat. And in these patients, they have a dual component. So they have the insulin deficiency and they have insulin resistance, which is more typical of type 2. And when you give them the GLP-1, they not only lose weight, but they improve A1C. And some preliminary results, take that with granulosalis, they're showing that the C-peptide, which is the marker of the insulin secretion, gets better in those with some residual insulin secretion. So it's not going to replace insulin, of course, but definitely helps not only the weight, the A1C, possibly the insulin to be better secreted.
You're there?
Yeah.
You just had a moment of interruption. So I think in conclusion, and we have just 3 minutes left, we are so still early on in this process. So just a take-home message, Dr. Iacobellis, that you can say to our audience tonight, hundreds who have tuned in, this is how huge a topic it is. It's like almost like a double-edged sword. Is this how many people we have pre-diabetics in our community and in our nation, full diabetics, that this has become such a huge issue to deal with. What do you say in the long run? Let's learn, let's be educated, let's stay on top of the science.
Yeah, definitely. So first of all, if you have diabetes, pre-diabetes, or family history for one of these conditions, so if you feel that you're overweight or obese, you should definitely consult us or at least an endocrinologist and seek for a professional guidance, not go on non-official and non-scientific website. That is it's a key message. And in my experience as a researcher, as a clinician, so these medications are very revolutionary, are very effective, and they seem to be very safe and with the multiple beneficial effects. So I see that these may become, they're already, but they are the present and the future for making ourselves healthier and living longer.
Yeah, unbelievable. And Elizabeth, I'm sure that you're going to say, stop the madness with the trends and eat much as you can properly and exercise.
Yeah, definitely all of the above. Definitely diet and exercise, more of making it a lifestyle change, really, not to get to a certain number on the scale. And also using different measures of how you're sleeping, how not just the number on the scale, but how you're sleeping, how your exercise tolerance is. Maybe you can walk a little bit longer or lift a little bit heavier at the gym as kind of success tools in your process of getting healthier, let's say. And I always like to mention, even if you don't have diabetes, checking your A1C is always nice to see maybe you have pre-diabetes. We always want to know where your A1C value is to be preventative, because if you are in the pre-diabetes range, then you can be very preventative and prevent having to need any new medications or anything like that if your A1C does become in the diabetes range.
Thank you all so very much for the privilege of your time. Our experts have been incredible, eye-opening for sure, to know that this is sometimes you need the medications, and I think all together as a big picture, a holistic approach to diabetes and weight management. There on your screen, you see all the information you need to contact the Department of our diabetes experts, umiamihealth.org/diabetes. There's the phone number. And please fill out the survey afterwards so you can give us some feedback and tell us what other topics you like. Everyone out there, stay well, stay healthy, and we will see you again. Good night, everyone.